So I'm going to talk about biomechanics of reverse shoulders with specific focus on lateralization. Charles Neer was the first to develop a shoulder prosthesis with the ball and socket geometry reversed. Unlike the native shoulder, Neer's prosthesis had a fixed fulcrum and was highly constrained with matched radii of curvature. However, similar to the native shoulder, the center of rotation was lateralized. This lateralized center of rotation created destabilizing forces on the glenoid implant interface, which led to poor outcomes secondary to component instability and loosening. Multiple designs were subsequently developed, which all had lateralized centers of rotation and a glenoid component neck. Additionally, glenoid component fixation was inadequate. Therefore, poor outcomes persisted. Paul Grammont revolutionized the principles of reverse shoulder arthroplasty with his first-generation prosthesis by changing the shape of the glenoid component into two-thirds of a sphere without a neck. This shifted the center of rotation medially, and therefore the undesired forces on the glenoid implant interface were minimized. The humeral component in Grammont's first-generation prosthesis was polyethylene, while the glenoid component was metal. Both components were cemented. Grammont's second-generation prosthesis was composed of 5 components. The base plate was uncemented, and the glenosphere was a hemisphere rather than two-thirds of a sphere, which shifted the center of rotation even more medial. Grammont's second-generation prosthesis was the basis upon which the current Delta prosthesis was designed and developed. Grammont-style prostheses in general have a medialized center of rotation and a neck shaft angle of 155 degrees. This minimizes the shear forces on the glenoid implant interface. Furthermore, the force required by the deltoid for abduction also decreases due to 2 reasons: a longer labor arm and a longer moment arm. It is important to distinguish between both principles as they are commonly used interchangeably. So the labor arm in red is the distance between the center of rotation and the point where the force is applied, which is the deltoid insertion. So with distalization of the humerus, the labor arm becomes longer. The moment arm in green is the distance between the center of rotation and the line of action of the deltoid. So with center of rotation medialization, the moment arm also increases in length. Despite the success of the Grammont prosthesis, there were a number of unsolved problems secondary to center of rotation medialization, including scapular notching due to inferior impingement, instability due to impingement, in addition to slack rotator cuff muscles, loss of external and internal rotation, again due to impingement, slack rotator cuff, and also less deltoid fibers medial to the center of rotation. So, as illustrated in this image, in a native shoulder, anterior and posterior fibers of the deltoid are medial to the center of rotation, and therefore can potentially help in external and internal rotation. With medialization of the center of rotation, some of these fibers become lateral to the center of rotation, which can have a negative effect on rotation. Finally, medialization resulted in loss of shoulder contour. So with the Grammont design, some patients simply didn't like how their shoulders looked like despite having a reasonable function. Scapular notching is a complication that's unique to reverse shoulder arthroplasty, with high rates reported, especially with non-lateralized designs, up to 96% in some reports. Notching can lead to glenoid osteolysis, loosening, and polyethylene wear. Methods to minimize notching include center of rotation lateralization, prosthetic overhang inferiorly, and decreasing the neck shaft angle. There's actually conflicting evidence in the literature regarding the effect of inferior inclination of the base plate on notching. In this talk, I will focus on center of rotation lateralization. So advantages of center of rotation lateralization include less risk of impingement, including inferior impingement, and therefore less notching, better range of motion due to restoration of rotator cuff tension, less impingement, and more deltoid fibers medial to the center of rotation, Better stability due to the same reasons, improved cuff tension, less impingement, and also physiological wrapping of the deltoid around the greater tuberosity. So looking at this illustration here, with lateralized designs, deltoid tensioning is more horizontal rather than vertical, and therefore improving joint stability. Finally, the native shoulder contour can be better restored with center rotation lateralization. So in any reverse shoulder prosthesis, there is a combination of compression and shear forces on the glenoid implant interface. Also, reverse shoulders, unlike the native shoulder, has a fixed center of rotation. Force vectors consistently pass through this fixed center of rotation. Compressive forces are represented by the horizontal arrow. Shear forces are represented by the vertical arrow. And the combined force vector is represented by the oblique arrow. So with non-lateralized designs where the center of rotation is at the glenoid implant interface, shear forces are converted into compressive forces. So the combined force vector is relatively more horizontal, adding the stability of the glenoid component fixation. With center of rotation lateralization, shear forces are more and compressive forces are less. So the combined force vector is more vertical. Furthermore, the combined force vector passes outside the glenoid implant interface, which creates a new destabilizing torque. So another disadvantage of center rotation lateralization is shortening the moment arm, which increases the abduction force required by the deltoid. So the deltoid needs to contract more powerfully for abduction, which can increase the risk of acromial stress fractures. Center rotation lateralization can be achieved either by implant design or by bone graft. Doing it by implant design saves some surgical time and allows more accurate control of lateralization. On the other hand, the rationale behind lateralization by bone graft is lateralizing both the center of rotation and the glenoid implant interface, which can potentially minimize the undesired forces on the glenoid implant interface, provided that the bone graft heals. Then humeral lateralization was developed to overcome some of the previously mentioned disadvantages. Generally, the rationale behind humeral lateralization is to lateralize the tuberosities, improving cuff tension and rotational range of motion, providing a more anatomic shoulder contour and improving stability, while the center of rotation remains non-lateralized, so the abduction force required by the deltoid is minimized, and also the shear forces on the glenoid implant interface remains low. However, the effect of humeral lateralization on impingement and notching might not be as effective as with glenoid lateralization. So one of the methods of humeral lateralization is changing the neck shaft angle into more varus. A valgus neck shaft angle increases the acromio-humeral distance and therefore allows more abduction. A more varus neck shaft angle increases the lateral offset, decreases notching, and improves all motions other than abduction. Humeral lateralization can also be achieved by using a curved instead of a straight stem. Another method for humeral lateralization is by using onlay designs. Onlay designs are those in which the humeral tray rests on top of the humeral stem. This design was initially developed for easier conversion of anatomic arthroplasty to reverses, but it could also be used to adjust the lateral offset by putting the tray medial or lateral on the humeral stem. Disadvantages of onlay designs include that more bone needs to be resected. Also, modularity creates a potential junction for failure. So by putting the tray lateral or medial, it's actually not straight lateral or straight medial. It's superolateral or infromedial. So by placing the tray superolateral, the humerus goes infromedial, which increases the acromio-humeral distance, decreases acromial impingement, and allows more abduction. Placing the tray infromedial increases the lateral offset, achieving all advantages of humeral lateralization. It is important to note that tray position does not change relative to the glenosphere. So putting the humeral tray eccentric has no effect on notching. So to summarize the effect of different designs on the deltoid, abduction force required by the deltoid mainly depends on the length of the moment arm. The longer the moment arm, the happier the deltoid is. So the best combination for the deltoid is a medialized glenoid and a lateralized humerus, as this is the design with the longest moment arm. A medial glenoid medial humerus design comes next, and glenoid lateralization with a medialized humerus is the worst combination for the deltoid. So interestingly, the effects of glenoid and humeral lateralization on abduction force required by the deltoid are opposite, and this has been proven by many studies. The effect of different designs on stability depends on where the tuberosities are. The more lateral the tuberosities are, the more stable the whole construct is. So non-lateralized designs are the most unstable, whereas lateralized designs improve stability regardless of the method of lateralization. How about subscap repair? Why is it even a question whether to repair or not repair the subscap in reverse shoulders? So in the native shoulder, the center of rotation lies in the center of the subscap tendon, whereas with distalization of the humerus and reverses, the center of rotation becomes above the subscap. This creates an adductor moment to the subscap, which increases the abduction force required by the deltoid. Also, subscap repair can antagonize posterior cuff and external rotation. On the other hand, advocates for subscap repair believe it can improve stability and internal rotation in addition to minimizing the risk of infection. So with glenoid lateralization, the abduction force required by the deltoid is already increased. So we don't want to make this even worse with subscap repair, which can antagonize the deltoid. This is why some studies suggest repairing the subscap in a more superior position, like in the bicipital groove, or even to the greater tuberosity in case the supraspinatus is already gone. This can minimize the unwanted adductive moment with the subscap repair. So in summary, reverse shoulder arthroplasty is a semi-constrained implant with a fixed and medialized center of rotation. Non-lateralized designs minimize shear forces on the glenoid and decrease the abduction force required by the deltoid. Glenoid lateralized implants decrease impingement and notching and improve range of motion. Humeral lateralized implants achieve a more anatomic position of tuberosities while maintaining a non-lateralized center of rotation.